So then let's say you have a 5-degree taper, and then you come in with a milling strategy where the burr is just coming straight down like this, and you're removing material, you're removing titanium by the burr attacking the geometry like this. Well, it doesn't take much to realize that if you only attack the axial wall like this, the tool can flex a little bit because you're loading it against the titanium and you have this long tool. And if the tip of this tool were to flex, say, 50 or 100 microns, it's still going to mill out the abutment. It's still, the surface finish is going to look nice. But what it means is that axial wall is now slightly bigger than the source file. Hello, Dr. Michael Cimino. Thanks for joining us again today. We're looking at a custom abutment and crown. Standard procedure for many doctors, but there's some uniqueness to the workflow here and how you had this designed and manufactured. And you're controlling some of the design elements yourself, and then you're benefiting from your manufacturing strategy. So why don't we just hear from you? Like, what are we looking at here? How did you make this case? What do you like about it? What's your process? Talk to us about this abutment and crown we see here.
Yeah, thanks, Rob. Thanks for having me back on. I love sharing knowledge and sharing what we do here at my office and how I can help other practitioners not only save money, but continue to deliver quality abutment and crown restorations. So what we're looking at here to the left is the separated abutment and crown. This abutment is a custom abutment manufactured by Atlantis, and the crown is a Rebel 3D zirconia crown. And I've got them here separated, and we're about to bond these together before delivery. And on the right is a dry seat, so we're trying on the fit, and you can see that the Rebel crown precisely fits on the abutment.
Let me ask you a curious question on this. So you obviously do the dry fit check to make sure everything looks good, and it looks good here. Do you try it in the mouth before you cement the crown to the abutment, I assume?
Yeah, good question. I don't. For 99% of these cases, I'm gluing the crown or bonding the crown and the abutment together prior to the patient appointment. And it's a smooth delivery to seat the crown and screw it in. Now, there on occasion, before I started using our Rebel crowns, I would have to adjust contacts if there's some type of path of insertion issue. For those of us that have been doing implant crowns, abutment and crowns, we understand the adjacent teeth are not always perfect to be able to smoothly seat an abutment and crown that's glued together. But I want to avoid as much cement getting caught under at the margin and below the gum line as possible. So I like to do a cementation outside of the mouth and then deliver it screw retained inside the mouth. For those that like to do seat the abutment and then try the crown on and everything, I just find that to be such a waste of time and a waste of a step, and it makes your delivery appointment longer. I like to just put these in and torque them down and close up their screw channel and maybe some minor bite adjustment if need be. Most of the time there's no bite adjustment, and it's a quick delivery appointment.
Yeah, there's a huge clinical benefit of cementing the crown to the abutment outside of the mouth, because then you can clean it up and you have no cement, residual cement inflaming or irritating the tissue, right? And so if you have a deep margin line for whatever reason, sometimes that can be difficult to clean. So cementing them together before you insert them is a big benefit, but then you have to have confidence in your digital workflow. So maybe walk us through how you gain that confidence to know that I can cement these together and this is going to be a pretty quick seating appointment.
Yeah. So let's talk about the history of how this even began in my office, because like most clinicians, I was sending my scans to the lab and telling the lab to make me a custom abutment and a crown. And unless you have a great relationship with your lab, you don't even know if they're giving you a custom abutment. They could be making you a crown on a tie base, and you're not even aware of it. And early on in my implant restorative practice, I was just sending it to lab and getting it back. And what I found was that they were just giving me stock abutments. and the crowns would debond. And it was a challenge to get the abutment out without having to use anesthetic and cut the tissue away because the platform was subgingival. And so it was just became a nightmare. And I got really frustrated with the debonds. So I changed courses and I talked to the lab, made sure that we were making custom abutments, but the price point was just getting out of control. And being a practice that was in network with most all PPO insurances, it became more and more of a challenge to bill out an abutment and crown, and the lab bill was upwards of $700 to $800. And I know that most clinicians are fighting this battle, and I want to share a way that you can continue to deliver quality abutments from a reputable company and make your Rebel 3D crowns. And you can get this for less than half the price of what you're spending at the lab now. So let's dive into it.
What was your all-in cost on that case? You know, custom abutment from where, and then your Rebel crown. Maybe just a general price range there of what that should be.
So the custom abutment made from Atlantis is anywhere from, depending on your area, being charged $250 to $270, and you can opt to get an analog model so that you can make any adjustments on a model prior to delivering in the mouth. That, of course, comes at a little bit of an extra cost, but for the most part, we're making these modelless and delivering without even checking contacts or anything like that. With that, and then your Rebel crown with your Rebel membership, you're going to get a discount on your Rebel crowns. And then if you're designing them on your own, which I'm going to show you how to do that, you can save even more. So all total cost in, you're less than $350. Whereas when the lab, you're getting charged $750, $800 sometimes for a custom abutment and crown.
In this case, you showed us was model free. No model with this case, and it went in.
That's right.
How was the seating appointment? Any major adjustments or pretty smooth, minimal to no adjustments?
No adjustments, no contact adjustments, no occlusal adjustments. It seats beautifully in the mouth.
Can't wait to learn more. Walk us through your exocad workflow here.
Perfect. Well, this is the finished product. So I'm starting with the finished product so you can see that we've got the crown and we've got the screw channel. And I'm going to show you how to line up your screw channel with the screw channel that was provided to us by Atlantis. So
it's an important step right here.
It is an important step. You want your crown, the hole in the crown, to line up with the abutment's screw channel. So let's walk through it real quick. I'll start with the Dental DB here in exocad. So we've got a demo abutment. We're doing tooth number 5, or site number 5 in this case. When you click on the particular tooth, you want to set it up by selecting anatomic crown. And then you want to do a screw retain restoration. And in this case, Atlantis is providing us with the file. So clinically, you're going to place an Atlantis scan body for that particular implant of your choice. And then you'll scan that and you will submit that to Atlantis. Now, in order to get set up with that, you'll have to call Atlantis and they'll walk you through downloading their software and how to submit cases to them. But you're in control of the design of the abutment. Atlantis is going to design it for you. They'll send you a preview of it. You can make changes to it. You can make it wider. You can make it, a little bit more subgingival. You can set all your parameters. We can talk more about the choices that I make when I'm designing my abutments, but they're in control of designing it, but you're in control of approving it. When you submit that, you're going to request a core file, which is what we're going to show you today. So the core file is the abutment, but in digital format. So because they're going to be sending you that, and it's really just like if you prepped a natural tooth, you're getting the abutment that is in space of where the implant is. So because we're going to be using a core file, not going to select scan body scan, we're going to select don't use scan body.
Yeah, so exocad's going to view it almost like a tooth preparation, right? The
Correct.
The approved abutment design that you approved with Atlantis gets merged into a new model that then looks like a tooth preparation from an exocad perspective, and then you're going to design a crown over it and put in a screw access hole.
Correct. Yeah, that's the only difference between making or designing a crown on ExoCAD just anatomically, you want to select screw retained and don't use scan body in this case.
Makes
All
sense
right.
to me.
All right, so let's move on. We're going to hit OK. We're going to save that. And we're going to start our design. Atlantis provides you with the files. So you're going to select the upper arch, which is the arch we're working on today. And then it's asking you for an antagonist. So this is what it looks like. Here's the abutment. Now notice it doesn't have a hole in it for this purpose of designing, but underside you can see my margin here, subgingival. So we're going to select our orientation and move to the next step. This is where we need to draw the margin. Now ExoCAD has a way to just detect your margin, and since this is not a natural tooth and our margin is pretty clear, I like to use the detect margin feature. So we'll click and then it automatically marks our margin. Pretty neat. Now, because I don't know where the screw channel is on this particular abutment, I'm going to switch to expert mode and I need to add Atlantis's screw channel. So we need to go to tools.
Here we go.
Expert mode. Go to tools and add a remove mesh. I'm going to select generic visualization mesh and then I'm going to load. And this right here, upper SAC, this is the screw access channel. And then it's going to ask me if the data is relative to the scan. I'm going to say yes. And then it automatically puts that screw channel right where it is in the abut. So I'm going to hit OK. I'm going to jump back to the wizard mode. And this is where you need to line up your screw channel with Atlantis' screw channel. So the gray is Atlantis' screw channel. And this is an angled screw channel. So I'm going to change the angle to line up with the hole in the abutment. You can
And my
widen.
guess is you're going to... Sorry, go ahead.
I was going to say that sometimes their channel is a little bit kind of off with its shape, maybe a little ovoid shape. So in order to make sure that I can get my driver through the crown to meet the screw, sometimes I'll widen the diameter of my hole. So I'm at 2.5. I think a big complaint, if I could add, Rob, that clinicians have with the lab technicians is that the lab technicians are using drivers that they get from the manufacturer that are very slim in the shaft of the driver. And a lot of times they don't make the hole in the crown big enough. So our drivers that we have clinically, the shaft is a lot wider and we have a hard time getting the driver through the hole. So you have control now when you're making your own crown that you can make the hole in the crown a lot wider.
That's interesting. I never heard that. So, I've seen a lot of labs, they use drivers that they'll, buy online from hardware sources, which are, they less expensive and you can have more drivers in the lab. But if the shaft is more narrow than what you're using, then it's not a one-to-one replica giving that technician a indication of what you're going to be facing.
Yeah, so we'll have to alter the screw channel with a handpiece, and if you're using a high-speed diamond burr to open that up, you are creating microfractures in the crown, which later that crown could fracture off.
Yeah, and that's going to be a lot of chair time sitting there adjusting a screw access hole, so we don't want that.
So let's move to the next step. It says error, please set your screw channel differently. Let me show you why that happened. So the screw channel is coming out the facial there. So what we need to do is move it and correct our angulation. It doesn't have to be perfect, Rob. It just needs to be over the center, because what we're looking at is the hole in the abutment, but we're trying to make the hole in the crown.
Right, so you just want the hole in the crown slightly larger than the hole in the abutment.
Exactly. Now, this is where it's very important to alter your cement gap. And Rob, you said you wanted to explain a little bit about why the cement gap is important when we're manufacturing a crown for an abutment from two different sources.
Yeah, go ahead and talk about your desired cement gap. And then I'd love to hear from you based upon what you designed here for your cement gap. Did you feel like what you received back from Atlantis and from Rebel, that you achieved that output, the cement gap that you designed?
Yeah, so in a natural tooth, I have a default of the cement gap of 0.1. And on a natural tooth, that works out just fine. But when you're dealing with a manufactured abutment and a manufactured crown from a different source, then sometimes seating the crown, when you get the crown back, it doesn't go all the way down on the abutment. It doesn't happen often, but it will happen sometimes if the design of the crown or how the crown was milled does not match the taper of the abutment. So what we're looking at here is the cement gap that the software has created, and we can alter that and make it wider if necessary in order to allow the crown to seat over the abutment. And I believe, Rob, you had a little depiction of how that works.
Yeah, I wanted to talk about tool flex and milling the axial wall of an abutment and the importance of that when you're milling an abutment to fit a crown. You have two separate geometries, two separate milling processes, and then you're going to fit them together. And that cement space, the cement gap, really acts as sort of the truth serum. Did both manufacturers do their job and produce an output, a physical object that matches the input STL file? Do you want me to show that?
Yeah, let's take a look.
So this came through many years of designing abutments and crowns and having them manufactured separately. So I was involved in a business where we would do design services and the lab would make their own crown and somebody else was making the abutment. And then sometimes we got a photo of the crown didn't fully seat over the abutment. The crown was held up by like 2 millimeters. And then we would do a cross section of the design and we would see there was adequate cement space in the design. And the drill compensation was turned on, and there was nothing in the design itself that was holding up the crown. There was no explanation of how the design could be at fault. So then if the design file looks good and the cement space was good and the drill compensation was turned on, and that's good, then where else could the problem be? Well, the only explanation is either the crown or the abutment, the output, the physical output didn't match the source file. And what we found was the axial wall of an abutment has got this, beautiful taper. Dr. Mike, what do you like? A 5-degree taper? Or, you don't want it too parallel, but you want, you like to have a little mechanical retention. What's the degree of taper that you like for the axial walls of your abutment?
5-6 degrees is great for mechanical retention, but also passivity.
So then let's say you have a 5-degree taper, and then you come in with a milling strategy where the burr is just coming straight down like this, and you're removing material, you're removing titanium by the burr attacking the geometry like this. Well, it doesn't take much to realize that if you only attack the axial wall like this, the tool can flex a little bit, because you're loading it against the titanium and you have this long tool. And if the tip of this tool were to flex, say, 50 or 100 microns, it's still going to mill out the abutment. The surface finish is going to look nice. But what it means is that axial wall is now slightly bigger than the source file. And the only way to really eliminate that is to have a milling strategy where you come in with an angle of attack that's a little bit more aggressive. And you can see here that if I attack the abutment from this angle, my tool's not going to flex as much versus when I attack the abutment at this angle. And so by doing that, your axial wall is much more accurate. It does increase the milling time a little bit and add some thoughtfulness to your milling strategy. But anyone that understands milling an abutment and milling a crown and putting them together, changing this angle of attack, and then that way if you mill it like this, your abutment file will match the source design file, and then your crown file will match the source crown file, because milling the internal surface of zirconia is not as complex, easy to achieve versus milling this beautifully tapered axial wall of a titanium abutment. So all this to say, whoever is manufacturing your abutments needs to be mindful that this is a split file, meaning that the crown is being made and the abutment is being made at the same time in parallel. And Dr. Mike, when you did your fit check, you're fitting two geometries together that were made in separate places by separate people, and they fit perfect. And the only reason they would fit perfect is if the physical output matched the design file that you gave them. So what it sounds to me like is Atlantis knows what they're doing, and they're using a more aggressive angle of attack on that axial wall. So then it's very accurate. And then when you go to seed it, everything is beautiful.
Yes, that's right, Rob. I can't say that this workflow hasn't had some hiccups. I've used different milling sources from labs to just all out, without mentioning names, just milling centers. And I had, when I first started doing it, I used unsaid milling center, and the crown came back and it didn't fit. And so my first thought was, well, you're not milling it correctly. I sent you a file and something's not right with your parameters of your mill. So they remilled it, and again, same thing. So then I went to a lab that also will design it. No discount, by the way. You send the file. They just charge you full on out if they had designed it themselves. And, it was fitting well. But then occasionally you'll have one that just doesn't fit right. But since I've been using Rebel 3D, they all fit, which has been great.
That's been good. In my experience, and it's not always correct, when the crown didn't fit the abutment, it was usually the abutment's fault, not the crown's fault as far as the geometry that you received. When that axial wall is slightly off, the only way to fix it in the crown is just to expand your cement gap, and you're sort of just arbitrarily accommodating more space in the crown so that it fits the abutment because the axial wall was slightly off.
Yeah.
So,
well, in speaking to cement gap, I'm going to share my screen again, and I'm going to show you where I put my parameters. And then, Rob, being the manufacturing side of making our crowns, you tell me on your end what you're doing with my construction file to maybe make those alterations to make sure our crown does fit.
The secret sauce is kind of a simple answer to a complex question. It's that your milling strategy removes material because it's a subtractive process, right? You're starting with a zirconia blank and a titanium blank in the case of the abutment, so that when you're milling, you're subtracting material out, and you're doing it in a way that's mindful so that the output geometry matches the input source file. And far too often in this world of dentistry, we fix it in the model, right? There's this idea of, well, many years ago, it was like, well, we just need to mill the abutment and mill the crown and then fit them together. And then we may have to do some lab work to adjust the abutment or to adjust the crown. But that really bothered me because I was like, if we're designing things properly and manufacturing things properly, there should never be adjustments. Or obviously that can occur, and we know we can fix things by hand. But for controlling variables, manufacturing against those controlled variables, model-less dentistry, model-free dentistry like you experienced is achievable with no adjustments, but it requires people to manufacture things with precision. So maybe let's take a cross-section of your cement gap and then take a look at what that looks like. And then can you throw the crown on as well? Or is that showing that?
Oh, yeah, let's do that. I'll bring up the final design here. So between the merge file and the actual abutment is 0.1. And that's how we designed this one. And that's the one that we see, this is the one that's been manufactured and seen in the photo. And did you take the construction file and make any alterations to the cement gap, or is that how you milled it?
We do not. We honor whatever the source file is with precision. We want to take accountability to manufacture an output that perfectly matches what you gave us. And then, also you can see here you should have some retention at the margins. So it looks like your crown file is actually, at the margin there, almost making contact. Or have you zeroed out that cement space there?
Yes, there's a zero cement space right there. And let's throw the photo up and zoom in.
Yeah, and I would say zeroed out cement space is aggressive. And if you've achieved it, that's awesome. Because what that means is both the crown and abutment manufacturer need to be perfect.
Yeah. Well, this is a dry fit. This is laying on its side. It's not cemented together. So there's going to be some movement in this crown as it's laying on its side. But if you put pressure on the occlusal surface, I promise you this will completely seat
Wow.
against that margin. This right here is exactly what you're seeing right here, is that little lip. And when I select my design for the abutments, I always ask for a shoulder instead of a chamfer because it gives me that additional thickness to be able to put my ceramic instead of a chamfered edge. But this is designed so that in milling, I watched your latest video with your milling guru, and he was talking about the issues in milling and the chatter and the chipping. So this is built in so that we're not chipping the margin.
Yeah, you got to have a little minimum. What is that crown border there that you have set? You're at a 0.01? Measure that line from the abutment out. Yep, from there to 0.22.
Yeah.
Okay. We probably could go a little thinner on that on some future cases. I'd love to push the envelope down to like a 0.1. I know Greg is comfortable milling that thin. You know, using the Harvest Nano Zirconia, it's a high density binderless zirconia, so it affords us the freedom to mill that margin line a little bit thinner. So, but excellent results. Super exciting to hear that it was you cemented the abutment, the crown of the abutment outside of the mouth, got it all cleaned up. So there's nothing to clean up in the mouth, and then you inserted it with no adjustment. That's pretty awesome.
That's honestly the way to go. So often are you seeing patients return from having an implant and a crown delivered from over 10 years ago, and they've got crustal bone loss, and you remove the abutment and crown, and there's just cement all stuck around the abutment at the margin. And it's catastrophic to the implant. People are losing implants because of it. And I know we as a dental community are more aware of that, and we're doing better by delivering crowns that are already glued on after or before we deliver. Now, some folks are old school. They may put the abutment in, cement it in, and then take it off. But I find that to be problematic because why cement it in the mouth if you're going to take it off and have to put it back in? So you're still going to be battling the same path of draw to put it back in the mouth. What is the point of gluing a crown on an abutment that's been seated in the mouth? You're battling the moisture in the mouth where that gingival sulcus it's got sulcular fluid. And I know that we're cementing a metal to a porcelain, and we're not dealing with a natural tooth and cement sepsis. However, why risk any of that and glue it outside the mouth and screw it in?
Makes perfect sense. You just have to have confidence in the insertion appointment. And if you do, then you're going to save chair time in your insertion. You're not going to traumatize the tissue with leftover cement. A lot of benefit there, saving time and doing better dentistry. And really all of this is rooted in controlling our variables, right? Like, you know, obviously you know what you're doing in the design phase, but then you need manufacturing partners that achieve an output that matches what you gave them.
Exactly. Yeah. So Rob, let's get into it. Let's design a crown here. So our hole has already been designed or positioned. And this next part is define your emergence profile. Well, all of that has already been done with our abutment design. So we're going to skip through that. And we're going to place a tooth. So exocad gives you an option of a tooth here, this generic option. And I'm a big fan of the Philippidus shapes. And I like to try to match as close as I can to the patient's existing dentition. So we're going to change that. And with the shift, we can make the crown longer. Shift and control, you can make the whole sides of the tooth longer, or you can just extend one side by holding down the shift button. And I like to just position it as close as possible as to where I want it to end up. You're not worried about interproximal contacts or occlusal contacts at this point. You're really just trying to get it positioned somewhere in space that you feel that it's going to fit well. At this point, is asking you about implant or abutment bottoms. We're going to skip through that because that doesn't apply because your abutment's already been made. Now, at this point, I've generated a pretty good design. Let's change our interference contacts to contacts. And so now you can see the actual contacts in MIP. And I can make the actual jaw scan go away. And I can use my smoothing tool to smoothen out any areas that are too bulging. Quite often, because of the implant position, you're getting this cantilever effect to make the tooth look a lot more natural. And I understand, that makes sense. However, I don't like clinically the cantilever because I feel like it puts too much pressure on the gingiva to get it to completely seat. Because sometimes when you try to seat a crown, if the base of it's too wide, that has to go subgingival. It's like, I mean, you're trying to squeeze a watermelon in there, and it won't. It puts too much pressure on the gingiva, and sometimes if you put too much pressure on that gingival sulcus, patients will return with the gums are swollen, they're oozing pus, and you've got to take the crown off and put the healing cap back on so that their tissue relaxes, and then you can go back and reseat it. But since I've been making these alterations, I haven't had any issues. So I like to taper the facial back just a little bit and smoothen it so that it is not so much of a bulge. It's more of a fine taper to the margin. And then it's all about really just making sure your interproximals are good and your contacts are good. So we'll adapt our static occlusion. And then you have some options in the proximal adaptation. Let's say, for example, we have this gap here, and we want to bring this into contact, but we want it to be perfect. So we can pull all sides to adjacent teeth and then select a proximal, and then it'll automatically adjust that to make the contact perfect right here. Now, when you hit a proximal, it also adapts the borders of the crown to the soft tissue. So you'll, this one, it's not really extreme as I've seen in other cases, but sometimes the soft tissue will impinge on the crown and you'll see these indentations. So I just go back in and smoothen that.
And Dr. Michael, you're available for training on this, right? If a doctor wanted to book a time with you to walk through an abutment crown design workflow in exocad, you're happy to book time and do some training, yeah?
Yeah, absolutely. I'd love to take a call from anybody interested in learning this workflow. I can explain how to get set up with making your custom abutments through Atlantis, and then explain that process. Once you have a core file and your abutment is already in production, then I can help you with getting your exocad parameters set up and how to design your crowns. Or if you don't have exocad and you're looking to start using Rebel 3D crowns and you want to use them for your abutments, then you can ask for me as a Rebel agent and send me your files, and we can get you started.
Wonderful. Love it. Love it.
So at this point, Rob, we're done. We've already got the screw channel selected, the occlusions where we want it, the interproximal contacts are where we want it, and I'm ready to merge this into a final restoration. This is asking about the screw channel, and we can turn this off, and it will give you a more smooth channel here. So I'll show you that once it merges. You'll see the channel right there, how smooth it is. In comparison, let's go back and we'll not switch that off, and I'll show you the merged file at that point. You see this lip right there?
Yeah. Yeah.
So if you switch off and merge, you're going to get a lot smoother of a
more natural occlusal table there. You don't have
and
that,
when you go
cylinder.
to close that off clinically, you'll put your Teflon tape in there and smooth it. It won't have the lip that quite often when I deliver these, Teflon tape, whatever composite you're using for your fillings, and I use Ivoclar's little padded instrument, and it works nicely to smoothen that composite. If I don't have to adjust the occlusion on the tooth itself, there's no need to adjust the composite because the pad already smoothens it as you're applying it, which is nice.
So what was your total seating time for this case?
It was the time it took to unscrew the healing abutment, seat the crown, and place my Teflon and composite. I mean, we're looking at 15 minutes.
That's a dream. Custom
Yeah.
abutment and crown, 15-minute seating. I think a lot of doctors would probably book an hour for that type of appointment, and maybe you can go a little less with some confidence that it's all going to work great.
Yeah, that's the thing. Having the confidence to deliver this modelless and know that it's going to seat. Now, sometimes when you have adjacent teeth that are in a position to where they really hinder your path of insertion, or your implant's angled in a way that you had to use an angled screw channel to get the screw channel to be right over the occlusal surface, then yes, sometimes putting it in and then having to shift it into the interproximal, sometimes these contacts can hold you up. And I think the mistake a lot of clinicians make is they start adjusting the contacts with a coarse diamond burr. And you really need to use dial lights and ceramic polishing wheels to adjust these, because you're scratching the surface of the crown, which is going to harbor plaque and bacteria, cause floss to shred as it passes through, and patients are going to complain about floss shreddings. Making that contact smooth so that it doesn't get damaged in that whole process is really important to use those ceramic polishing wheels.
Yeah, and Dr. Mike, would you highlight the contact areas in the design? I wanted to call out an important thing here that, prepping the adjacent teeth a little bit if necessary to make sure you have some flat surfaces on the adjacent teeth is really important. And then also a contact area that's as close as you can to the marginal ridge. You don't want, if the contact area is lower on the crown, you run a risk of path of insertion issues. And I want to zoom into the contact area without the adjacent teeth, and then just tell me, I would assume you would agree with this, if you do need to adjust contact, start from the bottom up, right? Because if the lower part of the contact is what's preventing insertion, relieve that area so then you still have contact at that marginal ridge. But if you wipe out the higher end of the contact and then you get it to seat, you might end up with an open contact.
Right. Yeah, that's a great point. If you're trying to seat this crown, and this is an angled screw channel, by the way, so if we take let's get the merge crown file off. Let's show you the actual angle of the Atlantis, and it's angled here because this implant was placed where the bone was, and it's coming out facially. So if we were to do a straight screw channel, the hole would come straight out the facial. But through Atlantis, you can request an angled screw channel, but the implant is still where it's at, and you need to get the base of the abutment into the implant, but sometimes that doesn't line up with being straight. With these angled screw channels, you may run into an issue of path of insertion because the contacts are where they are, or where they are at. You've got to put it in to meet the abutment, but then also slide it through the contact points. So it may get hung up here, but by using that polishing wheel, you can polish the contact a little bit, but not so much so that you polish away your contact. But on those, like you were saying, Rob, you want to adjust below the contact because this could be hanging you up. If you're inserting straight occlusally and the base of your crown is wider than that contact point height of contour, then yes, you're going to have to really adjust here because really you want your contacts here. It is kind of an issue when you adjust the contact so much. You're still getting floss to pop, but your contact point is now just up here instead of the broad contact that you had designed. So it can be problematic, especially with adjacent teeth. Quite often, the adjacent tooth may be ignored by, well, I'm going to say this just because our surgeons are also restoring implant crowns that they're placing, right? Nothing wrong with that. I think that's great. However, if the surgeon is only doing surgery and they're not doing restorative on natural teeth, then it becomes problematic because the adjacent tooth may have a restoration on it that is in the way because they've been missing this tooth for
Yeah.
quite some time. The adjacent teeth have drifted into the space. And in order to make an anatomically shaped tooth, because people, when your patients come in, they're not asking you for an implant. They're asking you for a tooth. And
Yeah.
that's what they expect. And so if this tooth is leaning more forward and this tooth has an existing crown, then we need to talk about replacing that existing crown so that we can have a better path of insertion and make a more natural sized tooth here and that's anatomically shaped, because it happens a lot in the molar area where we've got this big large molar, but if this tooth had been missing for quite some time and this tooth here had been drifted forward, then we're looking at making a micromolar. And
Yeah.
I hate trying to work with the space that's there. I always try to talk to the patient and explain, look, we can make you such a more natural sized tooth here if we replace the crown here and have better space. And not only that, but embrasure space is a big problem when it comes to implants, because look at this embrasure space. I mean, the implants that are being placed today are being placed because, or the size is being chosen because of what fits. And sometimes that is too small for what the natural tooth was. And when you lose a tooth, you lose quite a bit of anatomy. You're losing the facial and you're losing soft tissue, which leaves you with these embrasure spaces. And I quite often compare implants to light bulbs, because you've got a little base of a light bulb and then it broadens out to be a
Mm.
tooth. But the patients complain that they've got this space here. And, it's hard to get patients to understand. You got to set those expectations that, look, we are replacing a body part and it's not going to be the same as your previous tooth there. I mean, but it will give you back that functionality and having a tooth in that space that you're wanting.
Maybe for a future episode, we could talk about custom healing abutments and how you can use them to, spread the tissue or give the tissue a more natural emergence while they're healing. So then you have room for a natural emergence in the custom abutment design, because I know that's a critical element for tissue management, tissue profiles. If you just place an implant and stick a small healing cap on there, the tissue's gonna, heal in a parallel to the healing cap fashion, which then, you'll have to either slice the tissue and traumatize it to get that abutment to seat, or you're compromising the custom abutment shape.
That's very right. Yeah, you're correct.
Dr. Michael, this has been great. Thank you for sharing. Again, if any of you out there want to connect with Dr. Michael, you can reach him at rebel3d.com/Michael, and he's there to help consult, train, do whatever you need to help you in your digital journey. And thank you. Thank you for sharing, Dr. Michael.
Absolutely. Thanks, Rob. I'll talk to you next time.
Awesome.